do KT that has an impact in many ways. If you're a patient partner and others, it's a way to channel that experience to make differences right across the system. So we see tremendous opportunity for many people, and what we're trying to do with RISE is give you some sense about what's happening, when the times might be that are helpful for you to make a contribution. So that's the quick run through. So we'll open it up for questions and answers right now. Just a reminder that we can't answer policy questions. So if you want to know where the ministry's head is about thinking about the funding formula that might kick in 3 years from now, we can't answer that. But we're happy to answer questions about RISE and the central program of supports and anything related to strategy about how to support teams. So questions or comments? So, Harry, can I check with you first for the folks that are online?
Sure. So we have one question from online. Are teams across the province developing their own metrics to measure patient experience and population health, or is the ministry releasing any standardized metrics?
So right now, there's kind of an iterative approach where I think what's happening is there have been no proclamations about preferred PREM or PROM measures, patient-reported experience or patient-reported outcome measures. I think many teams are interested in it. Over time, it's likely to be the case that we move to that some kind of standardization, but in the short run, teams are kind of free to be thinking about this in whatever way makes sense. The ministry has in the full application identified a set of key metrics that it's particularly interested to see move. PREMs and PROMs don't figure prominently there right now, but that's going to change dramatically over time as the model evolves. So for those of you that work in the space of patient-reported experience measures and patient-reported outcome measures, boys, are there opportunities in the year ahead, and don't feel that the lack of attention to them now closes off those opportunities. It's just, the ministry is moving incredibly rapidly, always staying a step ahead of where the teams are. The teams are moving very rapidly, and they're prioritizing things that are essential at this stage. And the measurement of experiences and outcomes will come. It's just not a current priority. Huge opportunity. Questions from folks in the room. So we have a microphone. So just remember, folks are listening in remotely, so we want to be able to hear. We want them to be able to hear you when you're asking a question. So any questions from folks in the room? Your researchers spend time in educational environments, and you'll know that we're comfortable with silence, so we're going to wait until you have great questions to ask.
Hey.
Hi.
Ali Peckham, Senior Research Officer out of the North American Observatory on Health Systems and Policies. I would love to hear a little bit more about how, as an academic researcher, we can be involved and what that really looks like. I know I kind of have a level understanding now, but I'd like to hear a little bit more about that.
I mean, the great thing about everything that's happening in teams is the answers haven't been pre-specified. So my sense is you make it what you want from it. So, there are just so many ways that people can contribute. So you could end up getting involved in teams and helping them co-design an approach to monitoring and evaluation of a particular initiative they're doing. So if your passion is patient partnership, then that could be something that you could bring to the table. But I guess what we're focused on with RISE right now is less the research opportunities and more how do we channel what we already know from existing research to provide very practical support that is titrated to their needs at this time. And if I come back to two slides that had the same two words in blue, trusted relationships. On the collaborative governance slide, I had that in blue, and on the primary care leadership and engagement, that was. I would say the same thing to us on the kind of expertise side. If we can show the value that we provide to teams by giving them usable information that helps them at exactly the stage of the readiness path that they're on, I think the sky's the limit in terms of the future partnership opportunities. Whereas I think if we approach them now and say, I would love to do a 17-team randomized controlled trial that will take up, 10 hours of your day for the next 300 weeks, they're going to be a bit hesitant. So I think if we can build the trusted relationships, there are so many questions that can emerge And they're questions that can best be addressed from primary research, but also questions that can be addressed from secondary research or syntheses. So just this morning, we were talking about how a question that's coming up now is, what do we know about hubs? So, places that you can provide, many organizations can provide services, but when you walk in as a patient or client, everything you need is there, and then people just provide the services to you. So when questions like that come up, we can post that on the RISE community of practice, and those that are interested in evidence synthesis can hopefully say, hey, we can potentially mount a response. So long-winded answer, but lots of opportunity. For now, though, I'd emphasize how can we take what we know and give practical advice, and over time build the relationships that might enable primary and secondary research.
Could I just add to that? It's Jeremy Grimshaw. I think one of the ideas about the RISE community of practice is that this is a way in which, if you like, we can try and create both a community and a brokerage service that will allow people, make it easier to connect academics or patient partners or community associations with expertise to move forward. So I would sort of argue that there's some benefits to people in this room for connecting. One is it'll help you get a sense, it'll help you keep up to date about what's happening in this space, which is kind of useful because I found it quite hard to sort of have a really good sense about what's unfolding. And hopefully this will help us in these different communities to pick that up. But I think it also helps you potentially shape, how things are moving forward. That what we hope RISE is doing is helping the OHTs to think their way into these problems and develop local solutions. And you can help us by commenting on the RISE briefs. You've not quite got this quite right, or you've missed this. The expertise, the McMaster Group have pulled these things together amazingly well. But they're not the experts across all the areas we're going to cover. So if you could find ways in which I actually think this is needs to be a bit more nuanced or needs to be thought through, or there's other information you've missed, that would be great. The other thing is that we hope that you would help us so that if we are kind of trying to develop a brief in 6 months' time and we look across the community of practice and say, oh, actually, it would great to get Ivy Bourgeau's view in this. We might reach out to Ivy and say, look, Ivy, we're just trying to think about this. Help us think it through, and either just give us 10 minutes to sort of say, okay, here's 3 things to think about, or, she might give us a couple of hours, or she might help us actually write the brief. So, again, we will be reaching out to you, and there'll also, I think, be opportunities for folks to have some sort of brokerage issue, that there's an OHT that's really struggling with this issue, and there's someone in our, this kind of broad community that might help them think about it. And again, this is very much support, it's not research. We need to respect people's time, but it's trying to do those things, and so make it easier for us as academics or patient partners to get into, or to engage with the OHT communities.
I'll just add a couple of things. So one is that on this slide, you'll see, I'm just going to emphasize the point Heather alluded to, that what we've heard time and time again is governments saying they want to make sure OHTs have equitable access for support. There's a worry that if you're in a part of a team that has access to more resources, you're going to be able to do 50 million don't. As Heather alluded to, there's just so many assets across this province, and we just need to match the right ones and share those experiences. It would just be a shame to, to squander that. And the other piece is that those with expertise should have equitable opportunities to contribute to support. So one of the things that I've loved in Ontario over the last number of years has been the emergence of the Ontario Sports Support Unit, which is the first time I feel like we've had a centripetal force that has required groups to work together. And we want to broaden that with RISE so that if someone comes in with a question about hubs, if it turns out that a colleague at wherever, Laurentian University, has done amazing work on hubs, then we want to profile them. So we want to make sure that everybody who can contribute has that opportunity to make a difference. And then onto this point about you having your own work profiled, I'm just going to go back to the All Resources page. So as Heather pointed out, RISE will sometimes write resources, and as Jeremy said, we're very open to thoughts about how to strengthen them. But partners will too. And so if the North American Observatory comes out with a 3-page, here are 10 things you need to know as an Ontario Health team about topic X that you've done work in, fantastic, and then we'll make it available. So the hope is that it becomes a very efficient way for people to profile their work. We're also separately having a conversation with colleagues at the ministry, in a conversation led by Ann Hayes, about how can we also do some other stuff that makes connections with the research community. And so we will probably be adding web pages in the coming month or two that provide additional guidance to researchers about how to take advantage of this opportunity, but that's specifically for the researcher group. If over time folks have thoughts about how to better connect patient partners with experience, others that bring expertise, we're very open to thoughts about how to do that there as well. You were going over, oh, Ivy has the mic. Great. Hi, Ivy.
Hi, how are you?
Good.
Good. Yeah, I mean, some of the comments just cued me to another possible resource that we might be able to bring in. And so, you know, Agnes and I teach in the MHA program here. We have residencies, residency projects that they could be doing. Our Masters in Health Systems students also do residency placements. This would be an excellent opportunity, you know, for them. Even, you know, this notion of, you know, the 10 things that you need to know about topic X, you know, if there's a way that we could incorporate that into some of the work of master's and PhD students in the spirit of, you know, kind of getting them kind of ready for that embedded researcher like the Health System Impact Fellows do. So I'm wondering what structures would enable that on the webpage or the community of practice, and how might we incorporate that into, you know, the teaching or the curricula of these programs? And I just list 2 examples, and there's across the province.
Oh, great. I mean, I don't know what I can say beyond that. Those, you know, are great ideas that we're very open to. So if people are running courses where students have an opportunity to produce a document that is meant for application and impact, then if I were them, I would point them to the RISE website and say, look at all the rows that are empty where we need the 10 points on what do OHTs need. And then those students can then use the rest of the site to understand the language of, okay, so there's OHT building blocks, and then there's domains, and I see in the application they're using this language. And they can really start to craft a communication piece that is tightly targeted to their needs. Because as I mentioned before, these teams have such little bandwidth. But if they click on a student resource that is written specifically for them on exactly the topic, and it meets their needs, wow, what an incredibly exciting opportunity. And, you know, we can do things like track metrics so that if something ends up getting downloaded 1,000 times, we can share it back with the student or the faculty, and they can use that, you know, to show the impact that they're having. So we're very open to those types of things. And if you have other thoughts about how we can make the site even more transparent about those opportunities, then we're very open to it. And then to the Health System Impact Fellows, again, that's something that I know has been on Ann Hayes' agenda at the ministry, thinking about what an incredible resource that we have through Canadian Institutes of Health Research funding these fellows that are embedded in health organizations. The hope would be going forward, the Ontario ones are embedded in these teams. So right now they may be embedded in an organization that is a partner on a team, but the ideal situation is that they're actually embedded on the team. So much exciting stuff is going to happen at the team level. That's where the embedded opportunity is just going to be so high impact. So, Carrie, anything else from folks online?
Working? Yes, there we go. Okay. So I have 1 question that came in online and 2 that came in through email. So the first is, how can those with lived experiences get involved?
So I guess it's, you know, my comment would be it's the same as the other areas. It's to first to think about familiarizing yourself with the language and where these teams are going. Second, join the RISE community of practice so that you can contribute in your own right, but also see what other patient partners or folks with lived experience are bringing to the table. And then very pragmatically, in the short run, you can go back to that map that I showed you and think about approaching a local team. And if they're a team invited to full application, you have to keep in mind that they're trying to get to an October 9th deadline and might not have the bandwidth right now. But what they might say is, let's talk after the deadline has passed. If they're a team earlier on the readiness path, they might be very interested right now and already having a conversation about how they can have So for most people bringing expertise, their impacts are likely to be felt particularly impactful ways in local teams. But there's always going to be ways that once we identify those impacts, we can amplify them to the provincial level. So on Monday when we had the webinar, because of the regional sessions, we had a window into a variety of teams that had particularly innovative approaches to leadership infrastructure, and we invited them to present. So if we hear of patient partners doing great stuff supporting teams, we will also invite them and give them that provincial platform to describe what.
Great. So the second question is about ACOs, and it says, don't all ACOs include a physician payment? In what ways do we think ACOs would work differently without this aspect?
Yeah, so to me that's a bit of a policy question. So as a non-ministry staff person outside the ministry, what I can say is the funding model has not yet been set, and funding will continue to flow through existing pathways. So that includes payments to, let's say, hospitals, but it also includes payments to physicians. There have been no statements made at this point that there will be any change to that. In the long run, the ministry will come up with a single funding formula, but has not talked yet at any point about moving the physician budget under that. The single funding formula that would come in to the team and then go out to the participating organizations, hospitals, home care providers, other folks. Sorry, home care is to be determined, but the other existing providers. So again, the ministry is moving as fast as it can to deal with issues and is open to thoughts about where to go, but funding is a long way off. There are many, many steps that would need to get through before a team would even become eligible for funding. And so the ministry has a lot of time to work out the funding flows before it gets to that stage.
So the third question is, how are Indigenous communities being included in OHT proposals to engage them in the planning, design, delivery, and evaluation of services for these communities?
Yeah, so the ministry in the full application has put a lot of emphasis on the meaningful engagement of Indigenous communities. So all teams are expected to be thinking about this. We don't yet have a good read on what types of things people are doing. We know, though, from looking at the list of teams that there have been Indigenous-led self-assessments that are, I think they're in the teams in development stage. So we're seeing some interesting ideas emerge from that process. But there's no question that this whole issue of how do we meaningfully engage with Indigenous communities is one that there's a lot of appetite for learning about how to do that well. And what we're hoping to do over time is identify teams that are doing it in particularly innovative ways, in ways that Indigenous communities feel are valuable and are attentive to things that have happened in the past and are about a new way of doing things. And when we see those, our hope is to invite Indigenous partners to write about them, or for us to try and capture those experiences and then point people to individuals who can answer more questions. So I think it's early days, and if folks know of innovative approaches, we would love to hear about them because many teams are grappling with how to do this well. So we're out of time, so can I just check any burning questions for folks in the room? Okay, so just quickly, a final comment.
The last one is also likely a policy question. So the in-reach and outreach description of the processes involved in population health are super, but I wonder whether current interpretations of PHIPAA or the Personal Health Information Protection Act would interfere with the desire to carry out these activities.
Yeah, so, again, what I've heard come out of the ministry in webinars is statements that they are open to making changes to things, including legislation and regulation, when they're getting in the way. And I've been at many sessions where people have pointed out the problems with the legislation related to personal health information protection. So if you feel that PHIPAA is getting in the way of you doing the right thing, I would encourage you to send that communication into the ministry and be very precise about what the concerns are, because as with everything, they are signaling if there are impediments to doing the right thing for your population, they want to hear from them, and then they will consider what might be appropriate changes. So, but just be very specific about what is the problem and what could be a viable solution. All right, so let's wrap up. So thank you very much to those who've joined us remotely. We're going to sign off right now. It was good to have you with us. If you have any other questions or comments, you can send them to us at rise at mcmaster.ca. But most importantly, we hope that you'll join the RISE community of practice and will be willing to have conversations with your peers, with us, and others through that community, that online community. So thank you for joining us, and we'll sign off.